you push on that. Point it. Yeah. Yeah, here we go. Yeah. Oh, all right. It's my distinct pleasure at this time to introduce Dr. Rudolph Scrimenti, who will talk about the dermatological manifestations of borreliosis. As you all are well aware, he was the first person to describe erythema migrans in North America, reporting a case back in 1970, or publishing it in 1970. Dr. Scrimenti.
Thank you for the kind words. Good afternoon. First of all, I want to thank the Foundation for inviting me. It was a pleasure to be here. I either follow Dr. Lester or he usually follows me. We're fans of one another. The clinical signs and symptoms of Lyme borreliosis vary quite considerably, as you have already heard this morning and this afternoon. The serodiagnosis often lacks specificity, especially in early disease. Often, though not invariably, the cutaneous signs serve as landmarks for diagnosis and for staging of the disease. At this time, I'd like to highlight three dermatological entities which are unequivocally associated with this specific infection. And we're going to start out with a bang here, okay? Erythema migrans. This is the hallmark of early localized disease. Jim, if I sat down right now, we make up the half hour. Okay, this is erythema migrans, the hallmark of early disease, and this is probably best described as a macular area of erythema. It tends to be circinate somewhat. It's confluent throughout. This is a very common presentation. And I'm going to show you a lot of the common presentations, some of the uncommon ones as we go along. This is another lesion. Lesions on the corporeal surface, especially on the trunk, tend to be somewhat ovoid. So we're seeing a little bit of a different morphological picture here. This is an elongated oblong type of lesion with an advancing edge. And if you look centrally at this lesion, you see something else. You see that there's varying areas of erythema that are beginning in this particular lesion. This is an alternative lesion, but quite compatible with erythema migrans. There's something that really doesn't show up very well on this slide. I wanted to show you a lymphangitic spread. It was medial to this slide, but it didn't come on. It was a little comma-like affair. So lymphangitic spreads of erythema migrans are not common, but are seen. They're extremely common with other types of arthropods or insect bites, but have never really been reported with erythema migrans, and you should know that it does occur. Very characteristic lesion. This is the characteristic bullseye lesion. It's a nummular patch of erythema showing some inflammatory changes. This is surrounded by some relatively normal skin, and in turn, this is surrounded by an encircling, peripherally migrating red band. There's something else you have to look at centrally here in this particular picture. You're starting to get, in addition to erythema, some visible signs of inflammation. Now, how often does one see inflammation with erythema migrans? Well, probably in about 30% of the cases. When you do see it, it tends to be focally placed centrally. It does not usually accompany the lesion peripherally. You just see an erythema peripherally. So the secondary changes such as crusting, scaling, oozing, that sort of thing, obvious signs of inflammation are usually seen centrally. Now this is another oblong lesion on the back of an individual, and we're seeing something else here. We're seeing some small little vesicles. You can actually puncture these and drain some fluid. In fact, the initial diagnosis in this patient was herpes simplex. Indeed, herpetic lesions have been mistaken for erythema migrans. I'm trying to show you a few inflammatory lesions. I think there's a good clinical reason for showing you this. We're finding as we go along that there's a reciprocal relationship between inflammation, which appears centrally in erythema migrans, and the numbers of positive cultures that one can obtain either centrally or peripherally. This has really never been reported before. It will appear in the literature in the next 2 weeks. And I don't know how important that is, but it's a clinical observation we've made in the Middle West. So I don't like to culture inflammatory lesions, and if in cases where we have multiple lesions, I look for those that are not inflamed before I try to take a biopsy. That's an important clinical pearl, and I think we'll get higher yields if you remember that. Okay, now I've shown you some common things. I'm going to show you some relatively uncommon things. However, these are much more popular and they're very well known. In fact, they're considered to be quite characteristic, if not diagnostic, of erythema migrans. I'm going to show you in the next two pictures an expanding annular formation. In this particular slide, we see this is a bite site. There's some central induration. It's starting to move out at the periphery in a centrifugal pattern. And as we come proximal to the central portion of the lesion, the erythema is beginning to fade. Now, this lesion has attained approximately 25 centimeters in 3 weeks. The next slide shows a lesion that has been present for only 2 weeks. Now you're wondering, what am I showing you here? What I'm showing you here is a rim of erythema that is progressing peripherally. The central portion of the bite, which was right about here, has disappeared. The central area of the bite and the central erythema has completely disappeared. And if you do not use warm compresses on this patient when you examine them, you're going to miss this. This is a migratory erythema. It's tending to be annular. It's interfered with its peripheral migration because of the architectural structures that it's encountering in its peripheral path. So this is the best known example. This is what everybody writes about, but it's by no means the commonest clinical example of erythema migrans. It's an annulus, a true annulus. Actually, it's a polygon, but it's trying to become an annulus. Okay, this shows an annular lesion on the cephalic portion here of a child, and you can see the central clearing with an annular lesion. Why do I show you this? This is a very rare lesion. In contradistinction to adults, which are usually bitten about the body and the extremities, children are very often bitten about the face, the scalp, and the neck. And you very infrequently see a classical picture such as this. What you usually see is an area of erythema which is hidden by the hair-bearing scalp and just lines of erythema on the face or along the forehead. I think this is one of the reasons why when they report cases of erythema migrans in children, they report no more than 25% positive in contrast to a much higher percentage that we see in adults. And I think this is one of the reasons. If you're pediatricians and you're trying to make the diagnosis of erythema migrans in children, you must have good lighting. And the second good thing you have to make this diagnosis is a hair dryer. If you don't do that, you're going to miss at least 50% of them. Okay? That's a clinical pearl. Okay, within a matter of days and sometimes weeks, multiple lesions will appear, or as the Europeans call it, multiple erythema migrans-like lesions. In this country, these are referred to as secondary lesions, but they are synonymous one with the other. The most common appearance of secondary lesions in the United States are just nummular patches which tend to be either round or oblong, and they are diffusely reddened. There's really no annularity in the overwhelming majority of them, but I've shown you some other examples. As they appear, they tend to appear in crops, and all these crops seem to have the same shape. Some of them are polygonal, some of them are ovoid, some of them are circular or circinate, and they look the same as they appear in these crops. One crop might appear slightly different morphologically than another. They're bright red, but the bright redness rapidly fades. So after 7 to 8 days, the bright erythema is usually gone. Sometimes you see annular lesions. These are real easy to make a diagnosis of. They're not quite as common as the lesions that I showed you in the preceding slide, but this is what everybody talks about when they write about it, despite the fact this is really not the most common clinical presentation. Okay, sometimes we see bizarre examples of secondary lesions. Generally speaking, they are smaller, usually much smaller than primary lesions. This is the primary right here. But in this instance, it's much larger. These can be quite bizarre, quite gyrate, quite figurate, and in fact, sometimes the borders will intersect one with the other. In fact, you can even see triangular lesions somewhat bluer, and this is commonly seen in the bra area. It shows you that the erythema of erythema migrans tends to be influenced by pressure quite a bit. So it can look like anything depending upon what's compressing it. Now, I don't really know why I'm showing you this except to tell you that secondary lesions on the face of adults are very often non-diagnostic. The same holds true with lesions on the hands, and it's impossible to make this diagnosis in the majority of individuals if those are the only lesions. You've really got to take all their clothes off before you can make this diagnosis. Why do I say that? What we're seeing here is just swelling, some erythema. It's not very well defined. But on faces of adults, this is what you see many times. There's a dictum in Lyme disease morphology that Lyme disease never involves the palms and the soles. I'm here to tell you that that's not true. It does involve the palms and soles, but it doesn't do it very often. But when it does it, it's most often mistaken because these are the types of ill-defined lesions that one sees, generally speaking, on the palms and the soles, and they're fleeting. Quite unlike the type of lesions that one associates with syphilis or erythema multiforme. If you were to take a biopsy of an advancing edge of an EM lesion, this is what you see. A very banal infiltration, which is it's superficial, it's a little deep, but it's pretty almost innocuous, particularly at high concentrations. It's primarily placed perivascularly. It can appear in the interstitial spaces. If you take a higher up view of this, you'll see that the infiltrate is perivascular, it's intensely lymphocytic, and you can see it's made up of quite a bit here. Beautiful example of a plasma cell. If you were to do immunohistopathology on these lymphocytes, you'll find that these are the CD4 lymphocytes. If you were to stain the Langerhans stains with Langerhans stains, you will see that those cells stain very well in the epidermis and in the papillary dermis. Okay, generally speaking, it has been said that culture of lesions are very difficult to come by, even in skin. An article will be appearing in the Archives of Dermatology within the next month which contradicts this. But what I'm trying to show you now is what we've had to put up with for a long time before we were able to make this statement. This is a Walton Story silver impregnation stain of the epidermis showing the organism in the epidermis. You can also see this high up in the papillary dermis. You sometimes see this organism around blood vessels or in blood vessels. This is a very cumbersome stain. The pathologists hate to do it. They run away when they see me coming. The reason being that this stain stains virtually everything. It's very difficult to get resolution between the organism and the mucopolysaccharide material of the dermis, or at least the connective tissue ground substance in the dermis. But this is a Bosma modification of a silver impregnation stain of Steiner. It's a really nice example. And the Bosma modification is a very nice one. It's really been quite helpful. It's performed essentially as one performs most of the silver stains, except that it's stained with a much higher concentration of silver, and it's incubated for a much shorter period of time. In addition to this, it's incubated with hyaluronidase or amylase, which I think kind of dissolves away some of the slimy mucopolysaccharides or even proteinaceous material which encoats this organism and makes it a lot easier to see. This is a Bosma modification of the spinal stain. The differential diagnosis of erythema migrans is as we see it here, and quite frankly, this is a short list. It's a real short list. This is probably the most important slide that I will show you. And unfortunately, because of the constraints of time, I have no time at all to go over this slide. But so that you don't go home mad, I'm going to show you a couple, okay? This is an example of erythema annulare centrifugum, a euphonious sounding name. And in this particular instance, it is a cutaneous manifestation of a dermatophytosis, which this patient has on his toes. He responds real well to antibiotics. However, the antibiotic is griseofulvin. So, we see this with dermatophytosis. We see this as an immunological manifestation of sometimes systemic bacterial infections. We can see it as a cutaneous dermadrome of viral infections. It is commonly seen as a manifestation of drug eruptions. It also is rarely seen as a cutaneous dermadrome associated with an impending occult carcinoma. So when I see this, I know I've got a big, long work up ahead of me. But the most important thing is there's a real trailing scale. Scaling is really not an accompaniment of true erythema migrans at the periphery, but there's a hyperkeratotic scale which accompanies this red rash as it advances peripherally, a hyperkeratotic cupping. And this is another example that I want to show you. These are really archiform lesions. Archiform lesions differ from annular lesions in that the arc is broken. Here, here, here. So when you see that, you say, aha, it looks like it, but it ain't. What is it? In this particular instance, this is subacute lupus erythematosus, a very common manifestation of this systemic disease. In this particular individual, the patient happens to be photosensitive, has renal disease, and does have Rho-positive antibodies. And so on the basis of that, we can make the diagnosis very readily. The take-home message here is that this long list that I showed you on the preceding slide, you can probably rule out 90% of it with an ordinary punch biopsy of the peripheral margins. You do an H&E, you might want to do a potassium hydroxide, you might want to do a Beaver stain, but that's really all you need. That's really all you need. In the office, you can do these things. Okay, this is an example of a lymphocytic infiltration of the skin, a so-called Borrelial lymphocytoma, which is on the earlobe of a Swedish child. This entity of lymphocytoma is part and parcel of a constellation of variegated, ill-defined lymphocytic infiltrative lesions that we know very little about. And it's only one example of lymphocytic infiltration in which we actually do know the etiology, namely a Borrelial infection. And this is the commonest site that one sees this in children. The lesion itself is not associated nearly as commonly with actual bites, arthropod bites, as is EM. This bite might be placed perhaps on the cheek or somewhere else, and after a period of time, the earlobe becomes reddened. Lymphocytoma of the skin can be replaced after a period of time. It can last for many, many, many months by acrodermatitis, and it indeed itself can replace erythema migrans. So this is lymphocytoma borrelial etiology. It can also look like a tumefaction on the ear, on the auricle of this adult female. This is a lady from Vienna. I'm mentioning the place of origin of these lesions because these are rarely reported in this country, and our knowledge of them comes primarily from the European continent, although I do know that they do appear in American patients. But they really have never been thoroughly investigated. There's only one isolate that I know of, and that was in 1986 by Dr. Havmark in Sweden. And this is the commonest position where a location of a borrelial lymphocytoma in an adult, both males and females. If you were to take a biopsy of this lesion, this is what you see. You see essentially a normal epidermis with some effacement of the radioridges. You see a Brent zone, and you see a dermal infiltrative process, which is composed primarily of lymphocytes, some histiocytes, and occasional eosinophile, and they're tending to make germinal follicles resembling a lymph node. The most important thing to know is that when you see this, the chances of making this diagnosis are very, very good. However, as chance would have it, these pseudogerminal follicles are present only about 50% of the time, and are not required to make this particular diagnosis. The most important thing that we have to distinguish this lesion from is, in fact, a malignant lymphoma, and this can be done by immunohistopathological methodology. If we did this, we would find that these cells are composed primarily of polyclonal B cells with a smattering of CD4 cells and some eosinophiles, and that's about it. This is a differential diagnosis of borrelial lymphocytoma, and because of the constraints of time, we really can't go into this, but this is what I'm really primarily interested in. Okay, now I'm going to show you the third dermatological entity that's associated with Lyme borreliosis, namely acrodermatitis chronica atropicans. Now, it's hard to believe, but this was the first example of a cutaneous manifestation that was attributed to this disease, and it was first described about 110 years ago in Breslau. It was called idiopathic atrophy. So it was described essentially in its atrophic form. Also, several of these cases were actually shown at dermatological meetings in New York City and in the Bronx before the turn of the century. 35 cases were studied very extensively at the Mayo Clinic in 1945, and despite this, the American literature pales by comparison to the European literature. So if you want to learn anything about this disease entity, you've got to go into the European literature, you've got to see the cases, you've got to study the slides. Fortunately, for the purposes of this presentation, I've had several of my colleagues in Europe donate these particular case slides so that I can illustrate this to you. Acrodermatitis chronica atropicans exists in two stages. Number one, the first stage is a stage of inflammation, and number two is a stage of atrophy. They can overlap, but you may not see the stages of atrophy for many, many years, in fact, even for decades. The most important thing very early in this disease is that, number one, it almost always starts in the acrum. And number two, it's characterized by a purplish or violaceous discoloration that I don't usually see with other inflammatory processes. So this is acrodermatitis of the hand of a Swedish lady. Similar discoloration, you'll notice the purplish discoloration on the foot of the Swedish male. What am I trying to show here? Two things. With the passage of time, acrodermatitis disseminates. It disseminates centrally to the central body parts and then tends to become bilaterally symmetrical. This usually takes many, many months, if not many, many years. This is an example of bilateral acrodermatitis chronica atropicans. There's one other thing I want to tell you about this slide. This patient first presented to his doctor after a traumatic injury to the hands. It was an air hammer injury. And if you read the European literature, you'll come to the conclusion that many instances of acrodermatitis chronica atropicans do not come forward early in their course. Only after a relatively severe traumatic injury releases them from a state of latency. So I thought I'd show you that. Okay, and this is a cushiony type of obviously infiltrative violaceous plaque on the leg of a man from England who also had an associated plasmacytoma. Now, this, I think, is a very interesting lesion. As acrodermatitis disseminates centrally to the central body parts, it assumes this type of network-like or retiform configuration. I hope that you can see that well, and it's easy to see how this lesion can be difficult to distinguish from localized scleroderma or morphea. But this is a very, very characteristic lesion on the thigh. Okay? I've seen about 20 of these cases, and they all look the same. Looks like almost the same patient. So I'm going to keep that up there for you to see because it's important to know that. This shows ACA on the lower extremity, sharply demarcated at the buttocks. Generally speaking, as these lesions extend centrally, they stop relatively abruptly at the buttocks. I'm aware that there's one or two cases that are periodically reported of ACA on the ear or on the face, but those are very, very rare, and it usually stops before it proceeds cephalad to the buttocks. This is characteristic clinical finding in European patients. These are olecranon nodules, which are quite characteristic of ACA. Histologically, they show fibrosis. They might even show some fibrinoid necrosis, and on occasions you'll notice some epithelioid granulomas. They clinically have to be distinguished from rheumatoid nodules, from gout, or calcinosis cutis. These, I don't know if you can see this very well, but this is a pretibial band of fibrosis. They also occur over the ulnar area, so we have pretibial fibrotic bands and ulnar bands, which are part and parcel of the symptom complex that we call ACA. And this is a similar process in the foot. I want to bring this to your attention. You notice the changes in the small phalanges of this foot. You notice the purplish discoloration. This man also has a peripheral neuropathy. This is a painful disease. He has a tendinitis. This is an X-ray picture. Subluxations of the bones. This is seen in about 15 to 20% of the Swedish cases. This is not Lyme arthritis as you or I know it. This is an arthritis that is peculiar to the entity ACA. This has not occurred in any of the reported cases of ACA in the United States. Subluxation of the phalanges. Periosteitis very often is seen concomitantly with this. And this is end-stage atrophy. You can see the patches of atrophy. What you're actually seeing here is telangiectatic vessels, which are easily visualized through very thin parchment-like skin, which very often just breaks down and ulcerates and may degenerate to squamous cell carcinoma. In fact, lymphomas have even occurred as a late change with this entity. And that's atrophy of the foot. Nobody would ever miss this. Atrophy of the foot in a Swedish lady. Okay, histologically ACA looks like this. You see large vacuoles throughout the dermis. These are considered to be lymphangiectatic vessels, essentially. They almost look like large fatty globules, but they are indeed lymphangiectatic vessels. And you see an infiltrate throughout the dermis. This can be a very deep infiltration, and it can go out down to the fatty layer and sometimes even to the muscle. If you were to biopsy the dermis and do a monoclonal antibody stain for CD4 cells That's the predominant stain here, the predominant cell that's being stained here, CD4. If you did an immunoperoxidase stain on the dermal infiltrate, this is what you'll notice. These are stains within the cytoplasm of plasma cells, and this is for kappa, and this is for lambda short-chain immunoglobulins. And with this, I'll just end my talk. Thank you for your kind attention.
Thank you, Dr. Scrimenti, for your usual excellent talk. Our next speaker is Dr. Brian Fallon. He received his BA from Harvard and his MPH and MD from Columbia, and he will address the psychiatric aspects of Lyme disease in both adults and children. We look forward to this. Dr. Fallon?
Thank you very much. I'm very happy to be here. You might wonder, what is a psychiatrist doing here? Because certainly psychiatric problems are not listed in the CDC criteria. So I'm going to tell you a few stories that might give you an idea as to why I'm here. Someone I know wrote me a letter after I presented at a Lyme seminar, and she said the following: This woman has late-stage Lyme disease with encephalopathy and encephalitis at various points. She said, something you said at the Lyme seminar struck a raw nerve. It was something to the effect of, quote, Lyme patients feel that their bodies are actually killing them, destroying them. Well, it was something like that. Well, lately I've been thinking repeatedly that my body is literally committing suicide without my permission. I've told this to my husband on many occasions. He doesn't know what to say. I feel like Hal in 2001, multi-system illness, multi-system failure. Between headaches that are violently painful, palpitations, and frighteningly erratic heartbeats, weird and uncontrollable flickering eyelids, deadening weakness, and ongoing inabilities to think clearly, to talk without stammering, to remember anything worth remembering, I feel that the end isn't far around the corner. I don't even have to worry about suicide anymore, because like I said, my body's taking care of that. It depresses me to be so far gone, so unable to function. Like at the end of the movie Blade Runner, it's time to die. People are most conscious, aware of their bodies, when they're in great pain. When the pain is constant, violent, bizarre, and unrelenting. When the personality is bombarded too, well, the will to live likewise crumbles. You can rent and watch all the funny movies in the world, but it won't make up for the part of you, your personality, your spirit, that has somehow been ruined or destroyed. I think that's a beautifully expressive statement of what it's like for many of these patients with the more serious cases of neurologic Lyme disease. She identifies the multi-systemic nature of the illness, that it's associated at times with great pain. It has sort of these bizarre symptoms where you have perhaps an intense sensitivity to light. You have to go outside with sunglasses on, or intense sensitivities to sound. So you might have to wear headphones or earplugs in the house. It's waxing and waning. And so a psychiatrist clearly can be helpful to help a patient coping with an unusual multisystemic illness. Psychiatrists can also be helpful in helping a patient to deal with an illness that affects the central nervous system and may actually cause an affective disorder or a personality disorder. So that's the first story I want to tell. The second is one I've told before, and I think it's a wonderful case. It's a 60-year-old man who was previously completely healthy, who developed neck pain. And with the neck pain, it was quite disturbing, so he went to see a chiropractor, and then an internist, and then an orthopedist, and nothing really seemed to help. About a month later, he developed these jerks of his arms and his legs, and they were sort of isolated, random. But because of that, he went to see a neurologist. And he had an EEG, a CAT scan, a set of blood tests, and everything came back normal. And the neurologist didn't know what to do, followed this gentleman. About 3 months later, the man became clinically depressed. It only lasted, however, 3 weeks. It was intense but brief, which is kind of bizarre for an ordinary depression. And then about 5 months later, this man started to talk incredibly fast. His thoughts were racing through his head. He displayed bad judgment, and it was quite clear that he was becoming manic. And so with this strange, sudden manic syndrome and the constellation of movement disorder, and I forgot to say, he also, early on in the illness, had brief, like 1-minute-long spells of disorientation where he would become confused. With this whole array of symptoms, he was admitted to a neurologic institute. And while he was there, they did, again, a whole battery of tests, an MRI this time, another EEG, carotid Dopplers, everything was normal. So they didn't know what to do. The psychiatrist treated him with psych meds. He got a little bit better. His movement disorder got a little bit better. And we ended up discharging him with an unknown diagnosis of organic affective disorder, no known cause. He was being seen by a psychiatrist, not myself, who started to wonder, well, what could possibly link neurologic symptoms and psychiatric symptoms? And so he actually looked through this guy's records and saw that a Lyme test had never been done. So he ordered one, and the ELISA came back positive. He then called me up and said, what should I do, and could this possibly be linked? And I said, I don't know, but send a Western blot. And that came back positive. And then we sent him to Dr. Libner, who treated him. And this man's movement disorder and mood lability all abated. He was gradually tapered off the psychiatric meds, and he's doing quite well, apparently, in a 1-year follow-up. So that's a case of a gentleman who became manic, as well as had some unusual neurologic symptoms that seems to be strongly associated, perhaps, with Lyme disease. We can't prove it, but it seems highly likely. Well, everybody by now better know that Lyme disease is caused by a spirochete after all these lectures. Syphilis, as you also, I'm sure, know, is also caused by a spirochete. And as you know, syphilis has neuropsychiatric manifestations. And so we need to know about what the possible neuropsychiatric manifestations of Lyme disease are. And so that's what I'm going to be talking about. I get referred a lot of these patients, partly because I'm interested in Lyme disease, but also because one of my research interests at Columbia is hypochondriasis. And I think that it's a major error to inaccurately say that someone has hypochondriasis or has a functional psychiatric illness when they in fact might have something organic. Now, we've heard about the microbiology of Borrelia, and it's important for psychiatrists to know that it's similar to other spirochetes, that it can persist often in a latent manner in the host. It can evade an immune response, and it can penetrate cells. And it's important for psychiatrists to know about this, because this might explain why patients have persistent symptoms and perhaps why antibiotics may not be helpful or may only be transiently helpful for some patients, and repeated courses might be needed. Now, we know that there are central nervous system syndromes associated with Lyme disease, headache with meningismus, meningitis, and finally encephalopathy. And we also know that early on you might be more likely to see CSF findings. Later on you may be less likely, as Dr. Coyle pointed out. You've seen this slide already today, and this is very important for mental health professionals to know that in patients with chronic neurologic Lyme, about 90% of them have an encephalopathy. And the encephalopathy basically is a disturbance of memory. Oftentimes there's associated mood disturbance where the person is quite depressed, or a sleep disturbance. And it's also important to see that there's often a difficulty finding words. These patients, often when I see them in my office, have a very hard time expressing what's wrong with them. And for example, one patient said that instead of asking her husband to put food in the microwave, she said put food in she was trying to find the word, and she said put food in the radiator. So these things are funny, perhaps, but for these patients it's incredibly disturbing because they sort of know what word they're looking for, but they can't get it. Neuropsychological testing is a very helpful adjunct to the diagnosis of Lyme disease because oftentimes patients with the encephalopathy may have subtle neuropsychological findings on tests. So you may see deficits in memory, attention, conceptual ability, where they have a hard time dealing with multiple concepts, and in verbal fluency, where they have a hard time coming up with the words to say the things that they want to say. A very good test to do in the office, just to test verbal fluency, is to ask a patient to name as many words as, let's say, that begins with the letter D or F. And most patients can come up with between 15 and 20. A patient with Lyme encephalopathy may only come up with 10 over the course of a minute. Now, in terms of the reports on psychiatric symptoms during Lyme disease, in a Logisian and Steer article in the New England Journal of Medicine, 33% of the patients with chronic neurologic Lyme were thought to have what looked like a clinical depression. Olmsted and Kohler are two neurologists in Europe, and they independently wrote articles basically saying that psychiatric symptoms are common, ranging from agitated depression with suicidal ideas to a clinical picture of dementia. Packner, who was a neuro fellow at Yale, was asked to see a boy, a 12-year-old boy who was hospitalized at the Psychiatric Institute at Yale with the diagnosis of anorexia nervosa. He was extremely thin, he wasn't eating, he was bicycling compulsively. This kid had clear Lyme arthritis a few years earlier, still tested positive, and although his joints were not currently bothering him, Packner wondered, could there be something neurological going on that caused this unusual syndrome, which was anorexia in a boy? So he did a tap, and there was a CSF lymphocytosis. The kid was still seropositive for Lyme, so we treated him with IV antibiotics, and the anorexia nervosa went away. And that was sustained on 3-year follow-up. So it's quite odd. And certainly he also reported cases of a patient with subacute encephalitis with anger outbursts. I believe he did a temporal lobe biopsy and showed spirochetes. This is the German slide showing staging of neurologic symptoms along with staging of psychiatric symptoms in Lyme disease. In stage 1, you might see depressive mood. In stage 2, you might see an organic psychiatric syndrome such as an organic personality disorder or an organic mood disorder. And in stage 3, you might actually get psychotic disorders. Now, this slide was not very well documented. Nobody's actually looked at these patients and done a prospective study. But it's interesting that in Europe, they seem to think that psychiatric symptoms are present there among the Lyme patients, and there's not much written about it in the American literature. Now, I want to spend some time today talking to you about a study that I was fortunate to link up with at Columbia, which is where I work. The Child Psychiatry Department was doing a national study, and one of the sites they were using was Westchester. And what they wanted to do was to find out what is the prevalence of psychiatric disorders in the community at large. And this is a group of epidemiologists, Dr. David Schaffer and Dr. Hector Berg, who are doing excellent epidemiology probability sample where they went out randomly. They chose random communities in Westchester. They chose random households from random blocks. And I asked them to just add a question to their 3-hour battery of questions. And what I asked them to ask was to ask the parents, has your child ever been diagnosed as having had Lyme disease? In Westchester as a whole, 10% of the parents responded yes. And in northern Westchester, 20% of the parents responded yes. So this was quite surprising to me that it was that high. Perhaps not surprising to those who live in northern Westchester. So then I thought, well, this is fascinating. Now I'm going to be able to compare patients who were seropositive, or not seropositive, but whose parents said that the child had Lyme disease with those parents who said the kid didn't have Lyme disease, and see what the difference in psychiatric disorders were. And this is what we found. Now, it shows a slightly higher rate of major depression. Eating disorders were a little more common. Attention deficit disorder, ADD, was a little more common among the children whose parents said they had Lyme disease. and tick disorders, not the Lyme tick, but tick disorders being movements, were significantly more common among the children who supposedly had Lyme disease than among those kids whose parents said they didn't. Now this slide may look significant to you, but it's really not that significant. The most interesting thing about this study was that there really wasn't a whole lot of a finding. And this really puzzled me because having worked with children who have chronic neurologic Lyme, I know that they suffer a lot, that they go through periods of depression, that their memory problems can be quite severe, and they look like they may have an attention deficit disorder. So the only statistically significant finding here was on the difference of tick disorders. So what does that mean? What we then did, this sort of are the numbers. What I then did was I called up all those parents who allowed us to call them back to find out, well, what was the story on the Lyme disease. And what I found was that of the 20 parents who we called, 19 out of 20 of those kids were completely well. They had had a tick bite and a rash, got treated, or they had joint pain with swelling, got diagnosed and treated anywhere over the course of the last 5 years perhaps. So 19 out of 20 were quite well. 1 out of the 20 children had a encephalopathy, subtle encephalopathy that was continuing to trouble her about 4 years later. So the good news is that only 19 out of the 20 kids were doing quite well, and Lyme disease was a fairly insignificant event in their life. But 1 out of 20, or 5% of the children who had been affected by Lyme disease were continuing to suffer. Now, before I mention this slide, we're now doing work with Dr. Crisaro. He's a pediatrician in Westchester. He's referring us patients with chronic Lyme disease who are clearly positive for Lyme. And we're trying to take a look at what are the disorders that we actually see in these chronic patients, because this prior study really was looking at acute Lyme. And just anecdotally, what I've been seeing are things like attention deficit disorder that was initially diagnosed as that rather than Lyme, depression, conduct disorder sometimes, but not very often. And interestingly to me, because I work with a lot of OCD, obsessive-compulsive patients, obsessive-compulsive disorder I've been seeing in these kids. But the experience of Lyme borreliosis among children with the chronic symptoms can be extremely disabling. Imagine that you're a child and you're having these severe, terrifying headaches, photophobia, sonophobia, profound pains, shooting pains. So it's a very distressing illness, especially when it goes on and on. You tend to be afraid that you're going to lose your friends, and in fact, you may not want to see your friends. It's disruptive to school or family stressors, and kids often, instead of expressing depression as sadness, may act out and have conduct problems. And often you may hear them say, "Am I dying? And what's ahead for me in the future? Am I going to be able to go to college?" We did a survey, which I've reported before, and I'll just briefly go through it with Dr. Barascano and Dr. Ligner, and with many support group patients throughout the country, asking what were the psychiatric symptoms that you experienced during your course of Lyme disease. Now, just because you have a psychiatric symptom doesn't mean it has anything to do with Lyme disease. It could be concurrent and unrelated, or it can be concurrent and triggered by the stress of the illness, or it could be concurrent and induced by the infection itself. If you think it's concurrent and unrelated, then you should have the same frequency of, let's say, depression as you would see in a general community. If it's triggered by the stress of the illness, then it should be similar to the frequency of depression you would see in other chronic illnesses. And if it's actually induced by the Lyme infection itself, you should expect a higher frequency than you would see in other chronic illnesses. So we sent out a questionnaire. The Lyme patients, the average age was 35, and we had 2 control groups, patients with osteo and rheumatoid arthritis who were much older, and patients with lupus. Most of the Lyme patients were sick a median of 2 years, while the arthritis patients were sick 12 years, and lupus patients about 8 years. So clearly patients with arthritis and lupus were sick a lot longer. We asked them questions about depression and have you experienced depression during your illness? Now remember that the patients with arthritis and lupus were sick a lot longer. They had a longer period in which to experience depression. But what you see is that the Lyme patients reported far more depression during their briefer illness. So it does seem, at least from this study, that depression is somehow linked with Lyme disease. Either it's the bizarre nature and the uncertainty associated with Lyme disease, or the central nervous system features or problem, or definitely, I'm sure, both. 45% of the patients with seropositive Lyme disease have been asked to see a mental health professional. Some were asked because the doc thought they only had a psychiatric illness, and some were asked because they happened to have troubling psychiatric symptoms, such as deep depression, anxiety, feelings of being in a fog, violent thoughts, personality changes, uncontrollable mood swings. Almost half were treated with psychiatric medications for things such as panic disorder, depression, suicidal thoughts, sleep disturbance, and psych meds were often helpful, as were antibiotics for these problems. Now, importantly, antibiotics were helpful for the fatigue, the memory problems, the encephalopathy, and poor concentration, but the psych meds were not helpful for those problems. And about 1 in 20 patients were psychiatrically hospitalized for things like severe depression, seizures, myoclonic jerks, was it a conversion reaction, manic and depressive symptoms. I'm going to run through these slides. So a lot of the patients reported a sleep disturbance. Increased light sensitivity was quite common. Ringing in the ears was common. This is Lyme support group versus arthritis support group. Abnormal sensations of smell and taste. Word reversals when speaking, letter reversals when writing, memory loss, disorientation. A lot of patients, not a lot, but I've certainly heard it said in my practice that patients may get lost in their own town or suddenly feel disoriented. So in conclusion, just on what the psychiatric disorders are that have been associated with Lyme disease, certain major depression, bipolar disorder, schizophrenia. There was a wonderful case reported in Journal of Neurology recently where they actually were able to show intrathecal production of Borrelia in a 19-year-old kid who came to a psychiatric hospital with new onset catatonia and paranoia, and they also cultured Borrelia from this guy's CSF. Anxiety disorders, dissociative disorders like severe depersonalization can occur with Lyme disease. I've seen it. And it responds well to antibiotics. Now, what's the clinical experience of Lyme disease? I want to switch focus just a little bit. Lyme disease in the Wall Street Journal stirs disputes over treatment. Doctors are constantly fighting with one another over how long to treat, how many courses of treatment to give, and it can be incredibly hostile. So the experience of Lyme disease is to have unusual symptoms, so that you end up being disbelieved by your doctors, by your family, and you end up disbelieving yourself, because how can you still have symptoms when you've already been treated what everybody thinks is the right amount of antibiotics? It often has a waxing and waning course. One day you're fine, next day you're terrible. That doesn't make a whole lot of sense. There's uncertainty about diagnosis and about treatments. There's a fear of losing your job and the loss of health insurance. And so what does this uncertainty do? Well, for patients, it causes a lot of fear and or denial. And fear because you don't know what to expect, you don't know what to anticipate, you don't know what your future is going to hold for you. In many patients, it also creates medical activism. So a lot of these Lyme patients, and many of you in the audience, are incredibly active and know more about Lyme disease than most of the docs out there in the community. And it really is terrific because it's beginning to have an effect. Like I recently took the Lyme Disease Coalition of New York summary statement and sent it to some of the people who supposedly know stuff at Columbia, just so that they would be aware of what all the Lyme patients know. And it's very helpful because they want to be aware, they want to be one step ahead. And And they get very mad when Lyme patients come in and say, well, what do you know about spirochetes and fibroblasts? And they don't know anything about it. So what does it do for doctors? It causes them to deny that the patient's symptoms are real, or it causes them to deny that there are actually uncertainties about Lyme disease as a medicine. It can also lead to excessive objectivity, so they adhere to the CDC criteria solely and basically turn everybody else away, and they feel that they're holding proper medical standards. Or it can lead to a loss of objectivity where everybody gets diagnosed as Lyme disease who walks through the door. So it leads to overdiagnosis and underdiagnosis, and then it leads to referral to a psychiatrist. And so that places all psychiatrists in a quandary as to what to do and who to believe and how to figure this out. So what do? So what I do is I try to figure out in my own head, does this patient really have Lyme disease? And I think it's very important to keep an open mind about the fact that we don't know all the manifestations of Lyme disease. And we also know that the testing is not good. So we check the history for ticks, rash, make sure the proper tests have been done. You look for the typical physical symptoms, typical cognitive symptoms. You look to see was there improvement with antibiotic trials. You look to see if there was an initial Herxheimer. And hopefully the patient will have one of these or a couple of these which will support the diagnosis of Lyme disease. Now what could be the causes of persistent symptoms? Well, it's you've heard a lot in the academic literature about post-Lyme syndrome. Perhaps it's all fibromyalgia or chronic fatigue syndrome, or it could be an autoimmune disorder. I mean, it's certainly possible that Lyme disease triggers these things. It's also possible and increasingly evident that in some patients, Lyme disease causes a persistent infection that is not responding to antibiotics, and that's why people have persistent symptoms. Or from a psychiatrist's point of view, you also have to think about, is this a factitious illness? Is the patient making up symptoms in order to get some clear secondary gain? Or is there an unintentional production of symptoms? Could it be a conversion disorder? Is it a manifestation of depression, either unrelated to Lyme or related to Lyme? There's a lot of anxiety. Interestingly, a lot of severe anxiety disorders may have a lot of symptoms that are quite similar to the encephalopathy type symptoms that many of these patients have, with light sensitivity, sound sensitivity, hyperarousal, hypervigilance. It could be, in many patients, I'm beginning to think of it almost like a post-traumatic stress disorder, where they've had this horrible illness that everybody's denied that they have. It's like the Vietnam vets coming back and everybody ignoring them. These Lyme patients have been quite sick, and everybody's, until recently, been ignoring them. And that can create tremendous fear and anxiety. But just on the hypochondriasis somatization side of Lyme disease, before I go to this slide, I just want to state that I work with hypochondriacs. I work with somatization patients. There's a clear picture. There are clear diagnostic criteria for that. And usually it's a long history prior to the age of 30 of somatization or hypochondriasis. If you have a patient who comes into your office at the age of 34, has been sick for a year quite profoundly, and prior to that was extremely functional, you really, I think, have to wonder. You can't think that this person is hypochondriacal or is somatizing as your primary first item on the list. So take a careful history, or order neuropsychological testing. Pharmacologic strategies can be helpful, as can psychological strategies. Family and couples therapy can be extremely helpful, especially for families where their children have Lyme disease. And mental health professionals can be very helpful in systems negotiation, because the system out there is menacing and hostile sometimes. So I started just mentioning a little bit about syphilis. I'll just say that syphilis has been known to cause memory problems, depression, mania, psychosis, and personality changes. I hope to have conveyed to you today that Lyme disease seems to be able to cause a similar profile. So in conclusion, new onset psychiatric disorders like depression may be a sign of Borrelia infection, particularly among patients with late-stage Lyme. Other psychiatric syndromes such as mania, psychotic-like syndromes may also be part of the Lyme spectrum. Physicians need to be aware of these atypical psychiatric manifestations, and failure to be aware of it, failure to recognize it early may allow a curable infection to become chronic and disabling. So be aware. Thanks.
Start the next session, and on the handout it says, I believe, Lyme presentation different in the Midwest than in the East. That's supposed to have a question mark after it. That's what we're addressing. Is that ready to go? Okay, Lyme disease in the Midwest, different presentations than East Coast Borrelia. Is it there or not? This is what we tried to look at, especially in Missouri. Well, I like to start out with this quote. New opinions are always suspected and usually opposed without any other reason but because they are not already common. John Locke. Erythema migrans, I think we can all agree with this, is considered prima facie evidence of Lyme disease. Most people consider it pathognomonic. What's going on in the Midwest? Well, nobody would really argue with, this is the Mayo Clinic, this is a pathognomonic erythema migrans rash that they published in their newsletter. Here's one of my patients. Another one. And if you look at those and flip them back and forth long enough, it sort of blurs. So is it different? To my eye, it isn't. At least some of it isn't. But then I guess that's subjective. But this is what we need to look at. Is it erythema migrans? What are the criteria for it? If that's an erythema migrans rash, it's pathognomonic, what is that? And what is that? Well, here's an example of a Missouri case. This guy was cleaning out a fence row, had a tick bite in southeast Missouri. This picture was taken 17 days after the tick bite. This rash does not hurt. Doesn't itch. We biopsied that in 3 different pathologists, including Dr. DeRay at Harvard and Dr. de Koning in the Netherlands, as well as our local pathologists, found histology consistent with erythema migrans, and 3 for 3 found spirochetes. He had a positive University of Connecticut Western blot, positive Lyme urine antigen, negative RPR, and so on and so forth. That's pretty suggestive. I like this case because this is a 10-year-old boy that lives 5 miles from my office who had a tick bite there, then developed this rash. And this child was born in Missouri and has never, ever been out of Missouri, not even across the river into Illinois. And he developed a pretty classic erythema migrans. He also, on his Western blot at the time this picture was taken, had no bands whatsoever. He has a negative RA, negative RPR, and 90 days later developed IgG bands of 29, 31, and 41 in a 10-year-old boy. This one had a positive biopsy by Dr. de Koning in the Netherlands for spirochetes. I'm going to go through these pretty fast. These are just some rashes that we see. This is one of my rashes. This is Dr. DeRay, courtesy of him. It's my patient, but it's his slide, showing the spirochetes in the tissue biopsies. This one is the largest of 3 on this patient. She had a positive CDC flagellin ELISA, negative syphilis serology, negative RA. A funny thing happened when we studied some of these with the CDC. On the erythema migrans patients, on I believe about 37 or so EM biopsies, we did whole cell sonicants and I believe 44% tested positive. But when we did flagellin ELISAs, only a few tested positive. And then when I had the ER doctors draw random serologies or random blood samples out of the ER, none tested positive. So the wholesale sonogate ELISA was picking up something that the flagellin ELISA was not. I discussed this with Dr. Tilton, and he suggested that it would possibly be different bands, probably the leading contender being a 25 kD. These are the other two lesions on that patient showing, yes, Virginia, multiple EMs do occur in Missouri. That's the CDC flagellin ELISA positive. Here's another EM rash in Missouri. Well, we see a whole variety of these now the patients are alerted to come in once they get them. This patient's from northern Arkansas. About 200 cases a year have been meeting the CDC surveillance criteria in Missouri. Those are the aggregate numbers. This is the distribution. My office is right there, and then Missouri's Boot Hill. This is Illinois, Arkansas, Kentucky, and Tennessee. But it's starting to spread all over the state now as physicians are becoming aware, and more importantly, as patients are becoming aware. This had positive serologies, rashes following tick bites. This is a Lone Star tick. We have this on the poster session outside. We have some of these pictures. And again, courtesy of Dr. DeRay, this is the spirochete from that previous biopsy, which she had a positive wholesale sonogate at the ELISA and a positive ELISA at Dr. Wes Johnson's lab with negative rheumatoid and negative syphilis serology. Another fairly classic tick bite about 10 days earlier had, in addition to positive serologies, had a positive PCR. What we thought was going on is the Mississippi flyway, as I understand it, is probably the largest migratory flyway in the world. Not just ducks and geese, but buntings and mourning doves and all types of chickadees and so forth migrate up and down the Mississippi River Valley. And right here is where I am. And so what we thought was going on was that any outdoorsman knows that birds often are loaded with ticks, is that the ticks were getting on up here in Minnesota and Wisconsin and then getting off down in our area and infecting our patients. And I thought that was true, then I thought that simply wasn't true, and now I don't know what to think. I'm not sure. It seems to be one of those simple cases which is so extremely difficult to solve, and that's the enigma of Lyme disease in the south central U.S. These are the Ixodes scapularis, a.k.a. junior subjective synonym Ixodes damani ticks, that we supposedly didn't have. And I heard until I could throw up, well, you can't have Lyme disease in Missouri, you don't have the deer tick. Well, I accepted that, and we looked for other ticks, and then after we found other ticks, it found out, well, we do have the deer tick too. So that made it quite confusing. But what a lot of our patients were describing to me, they would come in with this rash, and I'd say, well, what happened? And they'd say, well, I had a tick bite, 1 or 2 weeks ago. You had a lot of tick bites before in your life? Yeah, I've had tick bites all my life. You ever had one do this before? No. Does it hurt? No. Does it itch? No. I saw an article, or my wife saw something, and I'm worried about Lyme disease, and I'd say, well, what kind of a tick was it? They said, well, Doc, it was one of those little spotted ticks, the kind with the white dot on the back, and they could draw it in the chart. Well, it so happens that the Lone Star tick is very unique. The adult female is anyway, and it has this white dot right in the middle of the back, and no other tick in the world looks like it. And it makes these histories from people who would not know a Lone Star tick from Godzilla pretty credible. I mean, they know what the tick looked like that they removed that preceded the rash. Not all of them have this, but enough that it's certainly significant. Well, probably for us in the Midwest, the biggest thing to happen since Willie discovered the spirochete is Dr. Oliver's work, removing the negative bias. The doctors are going to have to examine the patient and look at the patient and be a doctor. You can't just say, you can't have it because you're not supposed to have it. It doesn't occur here. That doesn't wash anymore because Ixodes scapularis ticks are fairly prevalent in Missouri. In fact, in northern Arkansas, in the counties right under the boot heel, less than 100 miles from my office, infected Ixodes scapularis ticks have been found, as well as infected amblyomma or Lone Star ticks. So now, we're going to have to look at the evidence. You can't just say it's not here because it's not supposed to be there. Well, we went out to collect ticks, and good tick pickers are hard to find. So, in fact, I couldn't find any. I had to conscript my family. This is my son. When we started collecting ticks to find out what was going on, this was before when we thought we couldn't have it, but we did have it because we didn't have the tick, which we now have. So you can tell this is a very exciting activity for him. My whole family is real thrilled about this. They got their T-shirts. This is my son here. Here's another thrilled member. Here's another one. Even the dog is running away. But by golly, we did get some ticks. We even tried little slogans. They were underwhelmed. But we did find ticks, and we did get those ticks examined. This is courtesy of Dr. Dorothy Fear at St. Louis University. And this is an H5332 monoclonal stain of an adult female Lone Star tick from my tree farm. And it's got lots of spirochetes in it. Now, one of the enigmas is that almost everybody who has looked at ticks in this area, when you look at them under the dark field, you'll often see lots of live motile spirochetes, but then when you go to stain them, it's kind of a mixed bag. Sometimes they will light up like a Christmas tree, and at other times they won't stain at all. And sometimes they will stain variably, which I know the University of Missouri has done some work now with some PCRs, and some of them will be positive by genus but not by species. But they also have some positive by species, which makes me think that in the South, or at least in the South-Central U.S., I think we have a lot of unknown heterogeneity at a minimum in the spirochetes, if not some associated Borrelia. Otherwise, I think we would have a better pattern, more consistency, better testing, easier culturability, and so on and so forth. We've got to explain what's going on. I told somebody a long time ago, I said, I'm not completely stupid. If I wanted to fudge the data, I would have made it a lot easier than I did. Here's an example of some of the work we've done. We collected 2,000 Lone Star ticks, and 2.3% stained positive with monoclonals. More evidence that Missouri ticks have not read the CDC's tick etiquette manual of accepted arthropod behavior. They're just sort of renegades. We even had a case of babesiosis in Cape Girardeau. But the CDC, well, we have a lot of PCRs too on patients and ticks, but not always. Sometimes some that I think just for sure should be PCR positive. Nothing. I can't explain it. We get it in the ticks, but not always. The CDC came in and we collected 3,100 ticks, and I don't know, they looked at over 100 and found a little over 4% to stain with antibodies to B. burgdorferi, but they stained variably. Some of them stained quite well, some of them hardly stained at all, which is what virtually everybody that has looked at these ticks in this area, or looked at the spirochetes in these ticks, has seen. Again, to my mind, that does not suggest absence of spirochetes. That suggests variability of spirochetes. And therein, we have a major difference. Dr. Oliver's article about conspecificity is in your book. Well, you know, they cultured B. burgdorferi in Oklahoma, Texas, all around us. I seriously doubt that Missouri is the hole in the donut. And this has caused, as some of you all have followed this dispute, I think is a polite word, quite a controversy. This is the New York Times, and it talks about, that doctor down in Missouri that thinks he sees Lyme disease. And so we thought we would help them out. So they wanted a plausible explanation. What's going on? It can't be Lyme disease because we didn't have the deer tick. So we explained that what happened was that in East St. Louis we had a syphilis spirochete that mated with a Lyme spirochete. And what we have in Missouri is Lyme disease. And you are most at risk when you become intimate with promiscuous strangers in wooded areas. Well, is it different? That was the title. Well, this is nationally. You get a big, on erythema migrans in Lyme, you get a big summer peak, a nice bell curve, and that's has always been in the Lyme literature suggestive of an arthropod vector. See if I can make this work. Well, guess what? That's what happens in Missouri, too. This is 90 and 91 data. This is not just Ed Masters. This is the whole state. This is from the health department. And here we have 3 years in a row. Just like the national stuff. Well, we looked at ticks. We thought, well, if we got this summer peak, what ticks are biting people when this occurs? And this was just done out of our office, so it's not all-inclusive, but it's the only data that I have. And we collected 165 consecutive embedded ticks off of people. And I know this morning Dr. Bergdorfer talked about rhipicephalus, the brown dog tick, and ehrlichiosis. In this series, we had one that was removed from a person. It was an embedded tick. I'm not an entomologist. I don't know how often they bite people, but I know one bit a patient in my practice. But most of these are amblyoma. And this is the summertime. We have Ixodes scapularis in the area. It's more of a winter tick, or we think of it more of a winter tick. And like I say, we also have infected scapularis in the area. Now, what is the relationship there? I don't know. I tend to want to posit that the scapularis is probably very important in maintaining it in nature, and that possibly the amblyoma comes along, and since it's such an aggressive tick, might be transmitting it to humans, but again, that's sheer speculation on my part. Erythema migrans again. Is it different? This is a turkey hunter. This is a positive PCR on the biopsy by Dr. Lefebvre in California. This is another one where the CDC and Dr. Fear both found Borrelia appearing positive staining spirochetes on her property, and she has this rash. Here's another nice one. Most of these have backup, or I wouldn't show them. This is a fascinating history on this little girl. She had been camping south of St. Louis at a little church-like camp, and they had like tick checks, and there were so many ticks that week that the kids kept count. It was like a race. She literally presented at my office with a history of 2 weeks earlier having removed 106 ticks. And 2 weeks later, shows up in my office with that rash. This one had virtually positive everything that we tested. Ticks like high-pressure areas. Enlarging rash back of the knee. Central clearing. This happened at Land Between the Lakes, which is between Kentucky and Tennessee, the lakes there. And she had removed an adult female Lone Star tick 10 years ago. And this was a PhD who was very adamant about what the tick was and what it looked like. And she developed a pretty nice EM 10 days or so later. Young turkey hunter. Little girl has one on her shoulder. We did the injection aspiration because I didn't want to biopsy it. I biopsy these as much as I can. And with the injection aspiration, it was sent to Texas A&M, and it was positive PCR using OSPE primers. This is a seroconversion tick bite. people talk about, I know Dr. Scamini alluded to this, sometimes ticks on kids will cause rashes that are not visualized. These people literally came in from the hills. But they had read something, and they knew enough after removing this tick 2 weeks earlier to go back and look. And they had a nice EM rash under there. And had they not done that, this would have been another little sick kid with no history of an EM rash. Mother needed to go back 11 days later after the tick bite. This is a positive PCR, and the language lines and configurations can affect. I know on the, especially around the groin, they're often elliptical. In this area here, they're frequently pie-shaped. The area of the body can affect what they look like. I see a lot of them on the feet, and they often don't have a history of a tick bite. I think maybe the tick gets pulled off with the socks or something. I'm not sure. This one is just starting, but he seroconverted in 2 different labs and had positive biopsies in 2 different labs. And one thing they see here, in addition to the perivascular infiltrates, we'll often see in Missouri a frank vasculitis on these. Again, that's courtesy of Dr. DeRay. This guy lived on the edge of a park, and he and his wife got so tired of picking ticks off. At night, they kept a mason jar beside the bed so they wouldn't have to get up and flush them all down the commode. It was too many trips. They would just pick the ticks off and put them in the mason jar and save them. Multiple lesions. Back of the leg, young turkey hunter. Front. Inside of the ankle. Outside of the ankle. This one was fading. He gave a history of 1 week earlier being a bright red ring. He also had one on his arm. Now, that's one thing where our patients are now learning to take pictures and to watch this. And somebody that I've taken care of for 20 years that I know is a very credible historian, I object to the fact that if this patient comes into me a week after this, but with this history and a picture of that rash, that it's not going to count. I don't think that's right. It has to be physician observed now, I understand. I mean, my goodness, if we doctors can't determine that. My personal approach is to try and get the patients to save the tick, test it if it's alive, because that helps us with the epidemiology, measure the rash, photograph the rash, and at the initial visit, I don't do serology. So I draw blood and urine and I freeze it, and then 6-8 weeks later is when I do the serology. And plus, then that way if somebody says, oh yes, doctor, but did you know that when that child was 6 years old, they vacationed in New England, and they probably seroconverted then. At least I can go back and try and see if they had antibodies before. I can also do other tests, or if I need to do a follow-up syphilis serology or something like that to rule out cross-reactive antibodies, I'll have the serum to do it prior to treatment. Well, is South Central Lyme different in the sense of sequela? If you'd asked me that 6 months ago, I would have said, well, it might very well be. I personally don't think we see as much arthritis as they do in New England. And so I tried to get, well, I'll go through some of this and then look at the data. Here's a nice case that's out there, the Lyme carditis. This guy has an EM rash spreading, and he developed a second-degree heart block while the EM rash was still visible. Probably the only guy in my entire practice who has no cardiac risk factors. He has no one in his family has heart disease. His cholesterol is 165. His blood pressure is 112/68. His serum ferritin is less than 200. He has a full head of hair. He has a non-sedentary lifestyle. His blood sugar is normal. He would make Gomer Powell look hyper. And we followed him for 20 months later, and he didn't have any problems. He doesn't smoke. He doesn't drink. He will probably live forever. But he got Lyme carditis. His only medicine was amoxicillin, which did take care of it, oral amoxicillin. He's had no recurrences. We also see, this is a soil scientist whose job it is to go out in the fields and get soil samples. He has an enormous tick exposure. He had an EM rash 13 months earlier. 8 weeks after that, had a Bell's palsy, then developed a migratory arthritis. Then 13 months later, presented to the emergency room with syncope and was admitted with episodes of ventricular tachycardia. We admitted him to the ICU, started him on IV lidocaine, and nothing happened. He kept right on doing that. Not until we started the IV antibiotics did that cool down. The cardiologists were quite skeptical, and this guy went through the mega workup. He even got angiogrammed. No evidence of heart disease at all. And he ended up being serologically positive and did well, but great history. Bell's palsies are real common. Next tray. I've also seen 2 6th nerve, 1/4 nerve in patients in whom we made a mega effort to rule out other causes and who had serological evidence of Lyme disease. He's trying to wrinkle his forehead. As you can see, the left half of his face isn't working. That's a 7th. That's a Bell's palsy. Here's another one. This is this guy's 3rd Bell's, and he's got all kinds of other symptoms, and after we treated him, he did great. He really did great. No more Bell's palsies. He felt fine. He was able to work again. I personally have had 4 patients in my practice who have had a sequential Bell's that ended up being seropositive. They had a Bell's on one side and then a Bell's on another. I still haven't had my first bilateral Bell's. 3rd nerve palsy. Again, worked up exhaustively for other causes. He ended up seroconverting and had a pretty dramatic response to antibiotics. Here it is here. This eye, he's looking straight ahead. This eye is deviating out. This is a 3rd nerve palsy. Here he's looking over this way, and he's trying to look up. And this is after just probably 6 or 8 weeks of high-dose oral amoxicillin. And that was after a long time of having that and being worked up. This doesn't show because it was fading. This gal had a tick bite and then had a basketball-sized rash following it. Non-pruritic, non-painful. I treated her at the time, this was 1988, with 10 days of Unison. And I thought she did fine until a year later she presented with a transverse myelitis. She was numb from the left nipple all the way down the left side of her body. Underwent an exhaustive workup at WashU. This was all documented. She seroconverted. She was treated with steroids and everything for months, and nothing happened. We put her on IV antibiotics, and she was normal in 6 weeks. We do see swollen joints. I personally don't see as many as what I thought other people saw. Here's a young deer hunter. 2 weeks after his deer hunt, he awakened and couldn't walk. He literally crawled to his car, and his wife brought him in. We worked him up, we tapped him, we looked for everything else. 2 days later, he couldn't move his left wrist, and he responded well to oral antibiotics. But we do see that. I can't say for sure that this is an eye finding, but this gal, for about a year and a half, had every couple of months or so, had a episode of iritis and uveitis, which was treated by the ophthalmologist. She then developed a lot of other symptoms. She had a positive spinal fluid, CSF PCR. We treated her with IV antibiotics. She felt great after that, and she never did have any more eye trouble. So I can't prove it, but it's suggestive. This young deer hunter, and the reason I know he's a deer hunter is because the reason he was in my office is he fell out of a deer stand. He had a huge contusion on the other side of his chest, but he also had a flu-like illness, had this rash, which was KH negative. We cultured him. I sent it to Texas, and it had spirochetes. They lived about 2 weeks or so, and they died. But not before we pictured them, used 3 different stains on them, and PCRs, which were all positive, and he also had a positive test, serology. So we know there's spirochetes in there, and they're not artifacts either. Which leads me to Lyme disease is a clinical diagnosis until you make it. And it's not a clinical diagnosis, at least not to that clinician. You better be able to defend it. And if anything else, I encourage you to document. Because not only is the patient often not believed, frequently the physician is not believed. The most effective clinical instrument used in documenting early Lyme disease is your camera. Take pictures. When I first saw this, I was the most skeptical of all. I would have bet probably everything I owned 6 years ago that there was no Lyme disease in Missouri, because if there had been, I would have seen it. Well, I was wrong. And so I knew when I started seeing it that I thought, my goodness, nobody's going to believe this. So I documented as well as I know how to document. 5 years later, it's still controversial. That picture is more convincing to me than any test you can get. Positive biopsy. Enlarging rash, that's not a heat rash, that's a 10-year-old prepubertal boy. And there's the spirochete. This is again Dr. Gray's phone. Positive. Tick bites, positive. This is an interesting thing we've seen. When we treat some of these disseminated cases, this is not an early EM. This is a central Lyme. This patient had a florid Herxheimer reaction. Felt like she'd been hit by a truck and developed this secondary erythema migrans with the administration of the antibiotics. We've seen that twice. Here's another one. This is a 16-year-old boy who was in a wheelchair. Again, here's his PICC line. And with his Herxheimer, he developed this secondary erythema migrans. At the end of his treatment, he could walk again. I don't know of any other disease that would do that. And the fact that he went from the wheelchair to walking is good enough for me. I really don't care what it is. Tick bite or spider bite. We've got a presentation on the poster session to show how to tell the difference. Okay, time's up. And Lyme disease is serious, folks. I didn't know until I had a patient that I brought in. We have a little follow-up questionnaire. And under comments, he put down, I don't know which is worse, Lyme disease or my first wife. Is it different? Well, this will take about 1 minute. We went to the Missouri Department of Health and categorized all the cases presented in Missouri from 1989 to 1992 that were confirmed by CDC surveillance definition. Okay? Put them into the categories: erythema migrans, arthritis, Bell's palsy. This is true arthritis now, they don't count it. Lymphocytic meningitis and so forth, second or third degree heart block. Cumulative totals for the entire state. And then the CDC had a presentation at the International this summer for 1990. 7,000 cases broken down the same way. Confirmed surveillance case definition. Okay? So we thought, how do we stack up against the CDC? In Missouri, in every category, we had as many or more sequelae than they did nationally. I was very surprised by the high number of arthritis, but then a lot of doctors in Missouri think that if you don't have arthritis, you can't